My topic is orthotic management of lower limb. So I am working at Santokba Dullabji Memorial Hospital, a private hospital in Jaipur, 500 bedded, recognized for postgraduate teaching and super specialty teaching in many subjects. The department was established by Dr. Pramod Karan Sethi, who designed and developed Jaipur Foot. So we developed many low-weight thermoplastic appliances in a research project funded by Department of Science and Technology, Government of India. So you will realize that few years back the maximum patient for orthosis were of polio and cerebral palsy. Now due to all these new causes of trauma, different spectrum of orthotic requirement is emerging, where intervention by PMR expert can make a difference in patient's life. And these cases are mostly due to polytrauma, high velocity injury, multiple fractures, head injury, spinal injury, then increased longevity requiring variety of musculoskeletal surgery like joint replacements, increased incidence of neurological disorder after COVID-19, terrorism, wars, natural calamities, industrial accidents, changing lifestyle. So all these causes leads to musculoskeletal problem requiring orthotic intervention. So increasing number of road traffic accident, diabetes, mellitus, cancer has increased in the demand of the prosthetic and orthotic devices. The number of the deaths in because of the RTA in 2010 was around 1,34,000. Now nowadays it is around 1,70,000 per year. Now you can imagine the number of disability due to road traffic accidents. The other causes are diabetes, cancer, fall from height, industrial accident, snake bite also. So you will clearly see the difference in the orthotics you prescribed for poliomyelitis and for these all road traffic accident and other causes. The polio is a relatively benign condition due to viral infection leading to loss of muscle power, mostly in the lower limbs, but in other on the other causes side there is multi-system involvement. Upper limbs are very uncommonly involved in polio. There is multi-system involvement. There is no bladder and bowel involvement in polio. No sexual functions are involved. No sensory involvement. Surgery is needed only when joint deformity develops. It is less expensive and there is no ICU care involved in polio surgery most of the time. Orthotic intervention is often successful and less expensive. But in other causes, the things are entirely different. There is multi-system involvement, surgery is very expensive, ICU care is needed for long, and result of orthotic interventions are unpredictable. So if you want to work in the field of orthotics or prosthetics, or want to enter some research and developmental activities, you have to make yourself familiar with some terms which I would like to cover, although Dr. Naveen in earlier lecture has covered some part of it. So strain it refers to the change in shape within the materials which may be visible or microscopic. Strain may be of two types, normal strain and shear strain. The normal strain is of two types again, tensile strain and compressive strain. So normal strain and shear strain, normal strain change in length after application of external load is called normal strain because force is perpendicular to the cross section studied. So it is designated by the Greek letter epsilon. Normal strain is practically dimensionless quantity. We talk in terms of microstrain. One microstrain represents change in length of 1 part of 1 million. So two types of the normal strain can occur, lengthening and shortening. When length of material increases, it is called tensile strain and is recorded as positive number. Shortening is a compressive strain which is expressed as a negative number. So normal strain is measured by strain gauge. Angular change or shear strain. When external load is applied obliquely in the cross section studied, the change in object is an angular deformity. This is called shear strain. Stress is generally defined as load per unit area, cross section area of the material. Stress is again of two types, normal stress and shear stress. Normal stress again two types, tensile stress and compressive stress. The stress is generally defined as load per unit cross-section area of a material. Normal stress, when forces are perpendicular to the surface on which they act. The ratio of force to area is called normal stress. This is designated by Greek letter sigma. If a force acting on particular area directed outward from the surface, it is called tensile stress. Conversely, when force is directed perpendicular into the surface in question, a compressive stress exists. Torsion. So torsion is the act of twisting or part that has been twisted resulting from a twisting force called torque. In physics and mechanics, it refers to the deformation of an object such as a shaft or a rod when its ends are turned in opposite directions, causing shear stress and angular strain. It also refers to medical conditions like ovarian torsion and testicular torsion, where an organ twists, potentially cutting off its blood supply. Torque, a force that causes machinery, etc. to turn around or rotate. So torque is a twisting or rotational force that causes an object to rotate around an axis or an axis of rotation. Now I'll take up some cases because I mentioned that the pattern of orthotic requirement is changing fast. So we got some cases which is very regular feature in our department after joint replacement surgery. So is a 84-year-old person underwent bilateral total knee replacement, started ambulation without any support, suffered due to fall. He suffered periprosthetic fracture on both sides due to fall. 4 weeks after surgery, you can see the fracture. So he was reoperated. On right side, mega prosthesis was inserted. On left side, plate and screw fixation was done. After 2 months, on left side, adequate callus formation was not there. Ischial weight bearing long quadrilateral top with 2 side bars attached to AFO was fitted. After few hours of gait training in parallel bar, he was allowed to walk with stick support on right side. So in such cases, even if you can restore indoor ambulation, it is a great achievement. So there was one more case, 80 years female, underwent total knee replacement on right side. He suffered supracondylar periprosthetic fracture, right femur due to fall. 2 weeks after surgery, stitches were not removed because she was diabetic. Open reduction and internal fixation was done with plate and screws. This is immediate postoperative X-ray. After 2 months, ischial weight bearing quadrilateral top KFO with 2 side bars, drop lock knee was attached to AFO was fitted. Patient became ambulatory with stick support on left side. This is X-ray after 4 months of surgery. This is the patient. KFO was removed after 4 months of ambulation. One more patient is 32 years, suffered fracture right leg bones and fracture shaft femur on the same side in road traffic accident 3 years back. Open reduction internal fixation was done for both, got infected at fracture leg bone site, implant removed, external fixator was applied, which was again removed after 6 months, bone grafting done, both fracture sites, discharge mixed with blood was persisting. So bed remained bedridden for over 3 years and multiple surgeries were done. This is the X-ray leg bones showing non-union. So the non-union persisted for long. For this patient, PTB orthosis with side bar, drop lock knee attached to the ischial weight bearing caliper was fitted, quadrilateral top was fitted. After few hours of gait training in parallel bar, he was allowed to walk without any stick, crutch or walker support. So patient standing with the orthosis, you can see PTB orthosis with quadrilateral top fitted to him. So this infected implant has become a menace. Almost every month I am getting 20 to 30 patients of infected implant from all over the country, which is rendering the patient completely immobile. Patient refuses to undergo surgery again, is financially bankrupt. So that time you are left with this option only. So this is very different type of case. So 32 years male, suffered osteomyelitis of leg bones at the age of 2 years. You can see he was treated inadequately at village. Tibialization of fibula was done in 8 years of age. In second stage, screw fixation was done in the same year. Lower screw was removed after 6 months. PTB orthosis was fitted with shoe compensation. This he could use only for few months. This was done at some other center. And there was a shortening of nearly 13 inches long. Severe varus angulation developed. Fixed flexion deformity, mild flexion deformity at knee joint, and subtalar joint mobility was completely reduced. You can see the picture how the leg is looking in anterior view and posterior view, side view also. This is the X-ray after tibialization of fibula and removal of lower screw. So he has been to nearly half dozen centers in the country where transfemoral amputation was advised, to which he didn't agree, his family didn't agree, got the appliance made locally in some medical college, was not comfortable with, even with elbow crutches support on opposite side. So somehow he came to us. At our center, he was fitted with appliance shaped like a PTB orthosis, attached to quadrilateral top with 2 side bars and drop lock knee with spring catch. EVA liner was also attached. Now a foot platform was created and was attached to Jaipur foot with the help of the polypropylene cylinder. You can see the picture. And he was walking without any external support of crutch or stick. And you can see the patient is standing, and this is the appliance, photograph of the appliance. So with the appliance, he is able to stand erect with equal weight bearing on both sides and walk well with swing phase knee flexion. Spring catch is a device which can stop the ring of the drop lock knee joint from dropping back, and it allows the knee flexion when you are walking. So the gait is socially acceptable, energy efficient, without any stick, crutch or walker support. He can walk up to 2 kilometers non-stop, completed his college education and got a job. One more case, this congenital pseudoarthrosis at leg bones with severe anterior angulation. You can see almost 90 degree of angulation, congenital pseudoarthrosis. She underwent surgery 15 years back, deformity recurred. He has been advised amputation at so many centers, which she refused. Family also didn't agree. She was also fitted with PTB orthosis in 2010, made at our center, can walk up to 2 kilometers. Just 2 days before she came for minor repair of the orthosis, she is walking well. She has completed her college education and doing her post-graduation in agriculture. So these are the areas where orthosis can help and PMR expert can make a difference. So usually it is the polio and cerebral palsy in our department. So any condition, I will take up that also. Any condition which reduces muscle power partially or completely is included in this group. Paralytic poliomyelitis is still the commonest condition leading to locomotor disability. This polio-free India, but existing cases of poliomyelitis keep coming. This kind of picture is not very uncommon in our OPD at least. I keep on getting cases from almost every corner of the country with this kind of problem. You can see the genu recurvatum. The other causes are cerebral palsy, spina bifida, meningocele, spinal cord injury, head injuries, stroke, nervous system infections, neuropathies, congenital deformities, fractures, delayed union, non-union, failed total hip replacement and knee replacement. To restore ambulation, different devices are used ranging from simple walking stick to long calipers. Now a word about conventional calipers. I don't know why some departments are still sticking to these calipers, but I think as long as LMCO is existing, no one is able to stop this. So there are some, not only few, there are a lot of complication with conventional calipers which we have stopped using long back. These are very heavy, made up of wood and metal. Swing phase knee flexion is not allowed, which makes the gait laborious and increases energy consumption. Much more hip flexor power is needed to provide the necessary thrust to initiate the swing phase. One has to raise the pelvis with hip abductors and trunk muscles. Ground clearance becomes more difficult as one is required to circumduct the limb. Presence of metal sidebars abolishes the subtalar joint mechanism, which is required to adapt to slopes and uneven surfaces. All joints in orthosis are placed external to our body, so they have to be congruent with the axis of movement of our natural joints. This externally imposed axis of movement increases external internal incongruence, and shoes cannot be changed. This looks very simple, but the changing of shoe is a very crucial point, very turning point in acceptance of the low weight thermoplastic orthosis. So these conventional appliances were replaced by low weight thermoplastic total contact appliances. Polypropylene was chosen because of the following qualities: a fresh homopolymer polypropylene, not the recycled one. You keep it in mind that if you use the recycled polypropylene, the patient is not going to be satisfied because it allows movement at many joints. So fresh homopolymer polypropylene is a cheap, flexible, available in milky white color as well as skin color, easy to use material, although it is very difficult to procure these days. Is available in open market, can tolerate repeated loading and its fatigue resistance. Small cracks can be welded easily. It is non-allergic to skin. Pressure points can be eased off easily with the help of heat gun. Good shelf life. Drawbacks of polypropylene is excessive sweating and not able to bond easily with adhesive to other materials. Prescription, earlier the prescriptions were based on muscle power provided by the physiotherapist, which do not provide any consideration for real life situation. So now our prescriptions are based on extent and distribution of paralysis, presence or absence of deformity, existing gait of the patient, and the real life situation. Patient may present with wide spectrum of problems ranging from simple limping causing socially unacceptable gait to totally bedridden conditions like complete paraplegia. The patient may come with the demand to get rid of the walker support with problem of frequent falls or progressive reduction in walking distance and speed. So there are some useful deformities and there are harmful deformities. Equinus and mild genu recurvatum is useful because they both help in stabilizing your knee joint. Calcaneus and fixed flexion deformity at knee, genu valgum and genu varum are harmful deformities. Now these are the appliances which has evolved over a period of nearly 35 years in our department. Linhais KFO is one, articulated Linhais KFO, PTB orthosis with ischial weight bearing quadrilateral top, PTB orthosis with articulated ankle. We have tried it in some patients recently with good results. FRO and FRO with quadrilateral top. Situation 1, there is completely flared lower limb, unilateral or bilateral, good trunk balance is there, upper limbs are normal. The KFO is fitted, which is similar to other KFO, but it is lightweight and shoes can be changed. And it provides very good rotational control to the hip. With the help of the two side bars, it is attached to AFO. This is distally attached to AFO with pretibial shell to stabilize ankle to ensure plantigrade foot. This is much lighter in weight and choice of the shoe is possible. In case of paraplegic, same appliance can be used with the help of bilateral axillary or elbow crutches with 4-point alternate gait or swing to or swing through gait. Then situation 2, when hip is stable and quadriceps muscle is weak. Patient is ambulatory with hand on thigh gait, where body weight is utilized from above via the hand to press the knee back to prevent buckling. This is very awkward gait which immobilizes one upper limb and often leads to problems ranging from back pain to scoliosis. This is a very common situation in our OPD. Saltiel in 1969 worked in Israel used flow reaction principle. So you have to understand this, that the center of gravity, when a line is drawn from center of gravity to the initial point of contact with the foot, that is heel, and the weight line, this is known as weight line. This is an imaginary line joining the center of gravity to the point of contact of the foot to the ground. Its relationship to the axis of the knee joint determines the stability of the knee joint. Here you can see the knee joint axis is anterior to this line. Now look at this situation. At heel strike, when weight line passes behind the knee axis, at this stage the quadriceps muscle has to contract eccentrically to prevent the knee from buckling. Here you require quadriceps power. So during hand on thigh gait, hand is used to press because quadriceps is not working the knee back to prevent it from buckling. So as the body moves forward, the progression of the center of gravity overlies the knee and weight line confers alignment stability to the knee joint. Quadriceps now stops working and at mid stance it shows no activity in EMG. Now the other option to achieve the knee stability is to bring the weight line anterior to the knee axis. So you can see in the diagram the weight line drawn from center of gravity to forefoot, and this is the basic principle of FRO. In FRO, initial forefoot contact generates the flow reaction which through lateral uprights reaches to knee crosspiece located in front of patella, leading to force the knee posterior in extension, thereby prevent buckling. So I said you have to use fresh polypropylene because of this reason, because if you don't use the proper material, the entire flow reaction generated at the ground will get absorbed at the lateral upright level and it won't reach the knee crosspiece. And this is the commonest reason of failure of FRO in many centers. So FRO improves walking distance, prevents falls, enhances quality of life. It has to be used with laced up shoes. Patient has to be trained for proper loading of the forefoot with the heel of the ground, trying to push the knee back. This is also very important. You have to teach him how to walk after FRO is made. So opposite side shoe may require half-inch compensation because heel is off the ground. So the degree of equinus is important. It should not be very high or it should not be very low. So after several trials, it has been concluded that the heel of the shoe should be half-inch above the ground level. Tendo-Achilles lengthening should not be performed in such cases. In calcaneus foot, heel has a tendency to descend down more. The degree of equinus in such cases has to be slightly more to ensure initial forefoot contact, if you are prescribing it in calcaneus foot. But calcaneus is usually, if the power in in knee flexors and hip extensors is good, then only it can work. So this is the design of FRO we devolved and is still using in many cases. Case selection in FRO is important. There should be no fixed deformities at hip and knee, no genuvalgum or verum, no calcaneus deformity, good power in hip extensors, hamstrings and plantar flexors increases possibility of successful FRO. Bilateral FRO is not feasible. Rear entry FRO is another one orthosis we are using in cerebral palsy, crouch gait, which helpful only in mild cases, to some extent in moderate cases. It prevents excessive dorsiflexion at the ankle. Now, modified Linhais KFO. This for geniorecurvatum, the design has been arrived after trying several options and works well. Equinus at ankle should be avoided. This is the Linhais KFO design. This is non-articulated. Now, to avoid this projecting supracondylar piece of the appliance, we have made it articulated. So whenever patient sits, the supracondylar portion bends with the thigh and the projection is no more there. So you have to be very careful while taking the mold. PTB orthosis you have seen earlier also, and I'll show you some photographs because of the time. It can be used in stretch fracture of the leg bones, fracture leg bones, ankle and foot. Avascular necrosis of the talus we have used successfully. Neuropathic ankle and foot, especially in diabetics, and any painful condition of the ankle and foot like degenerative arthritis. This is PTB orthosis. This is the inner portion which we call as tongue. This is posterior. AFO mainly used for treatment of foot drop. I think I can skip some slides because I have to show you one video also. So AFO is very, although looks very simple, but very useful appliance. Probably last year we touched around 1000 AFOs. It's a very commonly made appliance. if there is sensory loss, you can cover it with microcellular rubber, which is the same rubber used in leprosy patients. Metatarsal bar is very useful in metatarsalgia. Supramalleolar orthosis, these days very commonly made because we are getting a lot of cases of pes planovalgus. So these are some points which you have to keep in mind while training the patient. Always use the stockinette. Try walking in your department itself for 10 to 15 minutes, 2-3 times a day. Remove the appliance, check for any pressure point. If there is any, correct it, and then send the patient. Take home message: the orthosis and prosthesis is USP of PMR. Early intervention produces good result. Extent of disability is reduced. Quality of life improves significantly. Socioeconomic burden is reduced. Self-esteem goes up. This is the girl I mentioned in my presentation. Probably, I think this video, yes. You can see the 90-degree angulation, anterior angulation. She is using PTB orthosis. She is using it with Crocs, not even with shoes. She is a college student. You can see the gait. Few seconds more. You can see heel is off the ground in FRO.
Good afternoon, sir. Sir, I'm Dr. Ruth from Lucknow. I just wanted to know the difference between tone-reducing AFO and the usual AFOs that we prescribe.
Tone inhibitory.
Tone-reducing AFO, sir.
See, we made lot of tone inhibiting orthosis, AFOs in cerebral palsy and other cases, but the results are not very encouraging. So right now we are not making it, but if somebody requests for that kind of AFO, we can make it. But I'm not very much convinced with this tone inhibitory AFOs.
Okay, sir. Sir, what is the difference between these tone-reducing AFOs and the usual AFO?
See, in tone inhibitory AFOs, you have to dorsiflex the toes to make the metatarsal heads free from pressure, to keep the metatarsal heads free from pressure, because there was some evidence that by reducing pressure at this region, you can reduce the tone of the plantar flexors.
Okay, sir. Thank you, sir.
So there is actually a very good article on tone inhibiting AFO, and it actually depends, like Dr. Anil is telling, it's for the equinus. And if somebody who has a varus tone, like overactivity of tibialis posterior, then you can inhibit the medial head. Okay, you can put a soft one, you can give a relief. Similarly, if you have overactive peroneal, you can again change it. If you think that the metatarsal head actually stimulates to have a synergy pattern in extension, then you can give a soft metatarsal head on that. So what kind of tone you are trying to inhibit, you can do modification and then see how it works for you.
Thank you, sir.
Any other questions?
Good afternoon, sir.
Good
I am
afternoon.
Dr. Paris from AIMS Rishikesh. Sir, I wanted to know, are there any recommendations for grade 4 osteoarthritis knee patients? Any offloading orthosis that we can use for them?
See, the only thing is offloading brace you have to make, and this will give some relief to the patient, not much.
The PTB we can
No, PTB is not going to help in osteoarthritis knee.
Okay, sir. Thank you.
Sir, I am Dr. Chahat from AIMS Delhi. Sir, I wanted to ask in what conditions UCBL is indicated?
See, UCBL is a foot orthosis which you can use in many conditions where there is some very little deformity of varus and valgus. You want to control it at the hind foot. Then in many painful conditions of the foot you can use it. In forefoot adduction, in club foot, when forefoot adduction persists and patient is not willing for foot abduction brace, you, instead of providing AFO, you can provide UCBL foot support with straight inner border so that the forefoot adduction is not there, which can be used inside the shoes also at the time of walking.
So as Dr. Anil is telling, it is basically to control the hind foot or the subtalar joint. So when you are actually trying to subtalar joint, you have to have correction in the heel and you have to go a little bit above the subtalar joint. So that's UCBL, and the same qualities of controlling the subtalar joint you can get into when you design supramalleolar AFO.
Yes, supramalleolar works well.
But again, the thing is, everything is in mold. How you take the mold. So if you don't take a proper mold, probably it doesn't work and hurts you more than giving you any relief.
UCBL looks very simple, but it is most difficult appliance to make.